Good morning, everybody, and welcome to the fourth day of the 2022 Innovation Conference, Honoring Whole Person Care and Recovery and Communities of Color. My name is Maria Restrepo, and I do work at the Yale Program on Recovery and Community Health, and I'm the co-director of the New England Mental Health TTC Transfer Center. We are delighted if you are joining us for the fourth day. We are delighted you're here. If this is your first time, you are in for a fantastic day. This has been an amazing week, and we cannot be more grateful to our partners, William James College, the New England PTTC, and the New England ATTC. Today's presentation is brought to you by the New England Mental Health TTC Technology Transfer Centers. And yesterday we heard an amazing conversation about pathways of recovery. Well, now we'll continue this conversation, even more innovative in supporting people of recovery with resilience, purpose, and opportunity. A few disclaimer, this grant is funded by SAMHSA, and at the time of this presentation, Dr. Miriam Delphi Ridman is served as the Assistant Director of Secretary. All the opinions expressed here are the ones of the panelists, not SAMHSA's. A few housekeeping to remember: please mute all your microphones. Everything will be muted except unmuted at the questions and answer session. If you are in need of using closed caption, it is available to you by clicking on the CC icon at the bottom of the Zoom. We are recording this session, and like previous sessions, we will send in the recording to you. Information about CE and certificates will be in attendance, will be sent to you followed by an email. If you have a question during the time, please use the chat, introduce yourself. We're here to have an amazing and interactive conversation. We have plenty of facilitators who will answer your questions, and just raise your hand or just type in. At the end of today's day, we've been talking the entire week, we're going to be submitting a GIPRA link, which is the requirement of our funders for all the TTCs to complete a satisfaction survey that takes 2 minutes. So today is the day that we're going to be submitting that information. As the other days, our networks uses affirming, respectful, recovery-oriented language in all our activities. This presentation is going to bring you a sense of hope. We are avoiding using any labels, and please, no judgments on avoiding any assumptions today. For today, we are going to have the honor to really have the director of the New England Mental Health TTC, Dr. Larry Davidson, set up the stage for this amazing panel. We're going to be talking innovations, really spotlight that are solely working in communities of color. The first one is going to be the Armani Breakthrough Project, which is a cultural and faith-based recovery initiative for Black and Latinx communities in response to the opioid crisis. Then we're going to have a mindful moment. So that's going to be the morning, the first hour. Then we're going to move into the innovative collaboration between the school and healthcare centers, CBOs, to support youth mental health in New England. Then we're going to move into a very powerful and important conversation, which is understanding the expertise of lived experience. And you're going to be able to meet an amazing group of New England leaders, emerging leaders, established leaders in the region. At that end, we hope to have time for questions and answers. So with further ado, it's my pleasure to introduce the director, Larry Davidson of the Mental Health TTC. He's a professor of psychology and the director of the co-director of the Program on Recovery and Community Health in the Department of Psychiatry at the Yale School of Medicine. He has produced over 400 publications, including a practical guide to recovery-oriented practices, tools for transforming mental health care, and roots of the recovery movement in psychiatry. So I'm going to turn it over to you, and he is going to be introducing Dr. Cheryl Bellamy, who is the Joint Director of the Yale Program on Recovery and Community Health. Welcome, Larry.
Thank you, Maria. It's my pleasure to also welcome you all to today's final session of this innovative conference on innovations. It's been a rich, stimulating, and informative week of presentations and discussion, and we will close today by focusing on 3 innovative programs that promote recovery and resilience among communities of color. I would like to start the day by reviewing briefly the foundations of recovery that inform these programs. Next slide, please. Recovery is a relatively new concept in behavioral health, as for a long time, both mental illnesses and substance use disorders were thought to be lifelong sentences. That picture began to change in the 1970s as mental hospitals were closing and a variety of treatments for substance use disorders were being developed. Since then, both rigorous research and life experience has suggested that we'd gotten it wrong, that more people recover from these disorders over time than those who do not. Those of you who were with us on Monday heard John Kelly say that recovery rates for substance use disorders hover around 75%. I will add today that roughly that same percentage of people recover from serious mental health conditions. So recovery is not only possible, but it happens more often than not. We've also learned that rather than sending people away to hospitals or residential programs outside of the communities where they live to be cured by professionals, recovery happens in a person's everyday life in the community. In fact, having a sense of belonging to one's community provides a foundation for recovery, and therefore community inclusion should not be made contingent on recovering first. Similarly, people recover through their pursuit and engagement in valued social roles, like being a student, working, being part of one's family, or belonging to a faith community. They should not be made to wait until they recover to become engaged in community life. To paraphrase the Reverend Dr. King, recovery delayed is recovery denied. Finally, as recovery happens in a person's pursuit of a full and meaningful life in the community of that person's choice, recovery-oriented services and supports can be offered in the context of that life, not only in medical, psychiatric, or other rehabilitative settings. We can bring recovery into that person's day-to-day life. And two of the programs you'll be hearing about next are examples of such recovery-oriented approaches, one of which is situated in faith communities and the other in schools, bringing mental health and substance use disorders to people as they go about their everyday lives. Next slide, please. The first one, the Armani Breakthrough, combines the pursuit of social inclusion and full citizenship on the left with the promotion of the 8 dimensions of wellness defined by the Substance Abuse and Mental Health Services Administration on the right. And it is to Armani that we turn next. Next slide. I now have the pleasure to introduce our Armani Breakthrough panel led by Dr. Cheryl Bellamy, director of the Armani Project. Cheryl is an associate professor at Yale School of Medicine's Department of Psychiatry, where she co-directs with me, as Maria mentioned, the Program for Recovery and Community Health, and is also the director of the Office of Recovery Community Affairs of the Connecticut Department of Mental Health and Addiction Services. In addition to her own lived experience of recovery, Cheryl has experience as a frontline service provider, community educator and organizer, and a community and academic researcher. Her expertise includes developing and conducting community-based interventions and research, and involving and partnering with people living with mental illness, substance use disorders, trauma, and HIV. Her research examines sociocultural experiences and pathways to recovery in prevention and treatment. Cheryl will be joined today by 5 panelists who are part of the Armani Project: Reverend Robin Anderson, the Church Liaison; Sylvia Cooper, facilitator of the project's New Haven site; Pastor Jose Rodriguez, facilitator of the project's New Britain site; and Graziella Reese and Mark Costa, both site coordinators at Yale. I now turn the meeting over to Cheryl and the Armani Breakthrough Project panel.
Good morning. Hi. I'm so happy and thrilled to be with you all today for this Innovations Conference. Thank you so much for having the Armani Project and our team. I actually just want to say happy birthday to my mother. Today is her birthday. And my mother is a reverend in South Carolina. And I just want to thank her for helping me throughout all of my experiences of madness as I was recovering and as I still am on my recovery journey. I appreciate all that she has done for me. So thank you, Mom, and happy birthday. Next slide, please. So just a little bit about our team. I'm really blessed to be a part of an amazing team of, who's organized from the ground up to develop the Amani Breakthrough Project. And first of all, to my co-PI, Dr. Ayana Jordan, who is an addiction psychiatrist, powerhouse, and she and I have pulled together an amazing team of people, and you'll get to hear about some of their experiences with the Amani Project today. But please join me with acknowledging all of them, and a special acknowledgement to our churches, pastors, facilitators, and people with lived experiences who attend Imani and continue to provide us with information, sharing their experiences, so that we can continue to innovate in the area of providing supports to people experiencing recovery. So starting with the why, this is a poem that was written by my friend and colleague, Imani Harrington. Imani is a playwright who lives in San Francisco. She's also a woman living with HIV. Imani has lived with HIV for about 30 years. So starting with the why, we need you, our brothers, our sisters, our people. Help us reaffirm ourselves in loving ourselves. Hold us when we can't stand, because soles of shoes have traveled on our backs for so long. We need you, our brothers, our sisters, our people. And to me, it's the essence of why we do this work in the first place. I believe we all need to be reaffirmed in loving ourselves. And very important, we're in Connecticut. I just want to do a land acknowledgement. All land in Connecticut was once Native territory. It is our duty to acknowledge that many of the institutions where we work or conduct research are indeed on Native land, and to give thanks. Land acknowledgements do not exist in the past tense or historical context. Colonialism is a current ongoing process. We need to be mindful of our present participation in that. Thank you. So introducing the Imani Breakthrough Project. Imani means faith in Swahili. We aim to promote health and healing for ourselves and our communities. How we do this? By creating a sense of unity, that we are all in this together, and creating a sense of collective responsibility through a participatory process. And you'll hear more about that participatory process in a few. Thanks. Imani is funded by the state of Connecticut's Department of Mental Health and Addiction Services via SAMHSA's state opioid response funding. So we are really grateful to have been funded by this initiative, and they continue to support this initiative. So thank you to DEMIS for their support of this work. So more about the why. Why is it that we do this work in the first place? There are various disparities in terms of OUD outcomes, and we like to talk about this in terms of social determinants of health. And these social determinants of health are particularly impacting Black and Latinx persons with OUD, but also other individuals who are experiencing OUD. So some of those are the vicarious trauma, dealing with issues of racism, dealing with unemployment, and for many Blacks and Latinx people, that unemployment is steeped in a variety of ways, and particularly for people who are experiencing legal involvement and coming out of jails and prisons and having experiences finding employment, etc. People dealing with poverty and acute poverty, dealing with chronic stress, dealing with the results of redlining and other ways in which systemic forces have made it challenging for Black and Latinx people to experience equity in our system. Dealing with undereducation, dealing with lack of family support, and dealing with some of the policies that are that need to be changed to sort of level the playing ground for all of us. Another why is that Black and Latinx people are dying at disproportionate rates due to overdose. And as you can see from this slide, it speaks for itself. The rates for Latinx and for Black folks are increasing, particularly related to overdose. And this is really sad. We're seeing this in Connecticut. We're seeing this in Rhode Island. We're seeing this in Massachusetts. I mean, this is why Imani is developed in the first place. We know that for racial and ethnic minorities, that they are less likely than whites to seek mental health treatment, and that includes treatment for alcohol and drug use. That even when they do seek treatment, that compared to other racial groups, that they're less likely to stay involved in treatment. And often this is because treatment is not culturally informed. And access still remains an issue for Black and Latinx individuals as well. And this is where the Latinx and the Black church are really necessary and needed in the development of these interventions and working with communities to do something about this issue. Because we know that religion and spirituality are ways in which Black and Latinx have been able to cope with not only psychological distress, but with issues related to just living in our country, living from day to day. In urban Black communities, 65 to 85% of adults attend church regularly. In Latinx, that number is 70%. And attending church regularly these days, many of us are having to do that, virtually. Talk to my mother, she still makes sure that she goes every Sunday. Many studies really point to the ways in which churches are doing things to really help people who are struggling not only from mental health issues, but also from issues related to substances, et cetera. I'm now going to bring on our church liaison, Reverend Robin Anderson. And thank you, Reverend, just for all of your work. We know that without your assistance, we would not be able to do this work. And Reverend is really going to talk about our process of learning and learning from the communities that we serve, which first involve meeting with all of the community and really finding out what does the community want in terms of addressing these issues in our community. So thank you, Reverend Robin.
Thank you, Dr. Bellamy, and also Dr. Larry and the Armani team. What a great and marvelous team. And Dr. Ayana, who is also another phenomenal part of this team. I am so blessed to be a part of the team, such a great team that is doing such great work, monumental work that has been done. And I can say that because I have also myself been in the clinical field for over 35 years. And so what we are doing is things that I thought we should have been doing for a long time. And it's also showing that it's making a tremendous difference in a person's life. I am a pastor as well. And so in coming to the Armani project, the first thing that we did was that we really pulled all of our pastors and persons from the community together and to really talk about, the issue around opioid usage and also the epidemic that exists, even though we know that it is all, that the opioid epidemic was actually already in the Black and Latinx community. However, when it started to show up in other communities, then it became an epidemic. However, we came together and we looked at the fact that because most people don't realize, but churches are the one place that everyone comes for everything. And it does not matter whether or not they're a member of the church, but the church is considered to be an integral part of any community that they're in. And they also serve that community as well. And not because they're members of the church, but because we are in the healing business. and that we are in the business of providing for others and making sure that people get what they need so that they can continue to go forth in the quality of life, whether it's them or their family members or whoever it might be. And so we had this focus group, and in that focus group, one of the things that came out of it that pastors said very clearly, we need a different model. The traditional ways in which things are working are just not working. I'm seeing the same person, I'm going through the same thing with one of our people over and over again, and it just seems like nothing is not working. We need to develop a new model. And so that's exactly what ended up happening, that the group of us came together that was presented, the team of people, because none of us and came together and started looking at what are some of the ways in which we can do this differently. And so as a part of that, that's how the citizenship and also the combination of the 8 dimensions of wellness became so important. But also we realized too that as we choose churches to be a part of this, and churches that are willing to have the program come to them, they needed education. So we began to educate them around opioid addiction and also other addictions. We also educated them around ways in which they could also, the most different ways that they can actually work with people in the most effective ways. And we learned from them also some of the ways in which they were working with persons as well. And then we also talked about the fact of, who could really do this work. And so a big part of really doing this work, when we started out with 4 African-American churches, but they were churches that also, knowing the pastors and working with the pastors, knowing what things that they were already doing in the community as well, and the services that they were actually providing, so that when persons came to the church, that not only would they actually be able to receive the services that Armani had to offer, but also they could be connected to other services that they were also providing. And then also we discussed the fact that we cannot, this is not a program in which you want to continue to push membership. Now, if they become a member of the church, that's wonderful. But however, it is really to provide this service and to let people know that they are welcome. And so people were concerned about whether or not people would be comfortable with coming to a church, but everybody is very comfortable with coming to a church because, again, it is part of their community. And even though they may never join the church, they still see the church as a safe place to actually come. And then also a part of our educational process also was to help churches to look at, they said, well, we start this program because so many times people have come to us and they want to start something, but it doesn't continue and it stops. And so we looked at ways in which we can do some asset mapping to really develop a program that would be also sustainable as well, because many churches have case managers, they have social workers, they have doctors, they have lawyers, they have persons that work at the Department of Labor. So how could the church also really develop a ministry that not only will people be coming for Armani, but they also could be connected to this ministry that they could also create as well. So those were some of the things that continue to come out of this. And so the first churches that actually started, it was just phenomenal when they opened their doors and how people just poured in, like we've been waiting for this service. And it's in our community, and it's with people that look like us and that people that understand us. And so as a part of that, you're going to hear from the 2 facilitators, one from New Haven, but the New Haven program was one of the first ones that started and continues to be a great, viable program. And I think their first graduation, there was 70 people that actually completed the program. And then also later on, we added the Latinx churches, and that also continued to be phenomenal in terms of the persons that are coming. And as you see the data, you're going to see, based on traditional programs and what Armani has done, because it is in the community, because it does have people that look like them, because it is the church where people either they go to the church, they've gone to the church, their grandmother has gone to the church, their aunt has gone to the church, and it's a safe place, and that they're able to connect with people that are right there to be able to meet their needs. And so a part of the project was also that it's 12 weeks. They come weekly for the 12 weeks. And then also they are actually given in many different creative ways in which people provide for them in terms of food. Some people cook a whole meal for them so that they're able to eat a hot meal. Some people also, were creative in terms of being able to have them. Sometimes they contribute. They wanted to contribute also to the food. And then they receive a $10 stipend for coming every week. And everyone's like, oh, what about the $10 stipend? But after a couple of weeks, they forget all about that they have it. And one particular group in New Haven actually took their stipends and decided that they wanted to give it away and help some other organizations in the community. And so they took the money and put $1 towards it and gave, at the end of the program, gave their funds to another organization to help. And then we also, after the 12 weeks, the pastors came together, in which we often talk and meet or whatever. And they said, well, what's going to happen after these 12 weeks? They're so engaged that we can see the difference in them. Things are really working, and they're looking, they're wanting to know what's going on next. And so that's where we developed the 10 weeks of next steps, which would also help them to get connected and continue to connect to those things that will help them to continue to go forward in their lives in terms of whether they're reducing their use or whether or not they stop using, or whether or not they decided that they needed to go to another level of treatment. And so now the program is 22 weeks that they actually go through the program. And we have certainly seen tremendous difference. And I know that they will actually show you the data. And I tell anybody and everybody, and all of the churches and pastors will probably say the same thing with one voice. This program works. It's making a difference in the community. And we continue to see great results of it. And so I'm going to turn it back over to Dr. Bellamy also, so she can continue the presentation. But I tell you, what an awesome program.
Thank you. Thank you, Reverend Robin. If you could go to the next slide. So yes, because of, Sylvia and Pastor Sylvia Cooper and Pastor Jose Rodriguez are facilitators for the Amani Breakthrough Project, and they're going to now share some of their experiences. I know we don't have a lot of time, but Sylvia, if you can start and then pass it over to Pastor Jose. Thank you.
Good morning, everyone. Thank you so much for having us on this platform. Thank you to Dr. Bellamy and to Mr. Davidson for allowing us to be present with you. I've been a Amani Breakthrough Project facilitator going on 4 years this coming April. It was something that it was unanticipated in my life, and I didn't work with individuals, but families who were homeless, as well as the rental assistance programs. What is a life like for the Amani Breakthrough Project participants when they come through our doors? And Dr. and Reverend Robin Anderson set it up for us. It is a non-judgmental zone, a place where folks can come. It doesn't matter what religious beliefs you have in your life. It is a place where people come to be individuals, as well as sharing their experience in their recovery journey. The 8 dimensions of wellness is laid out for us. It is a foundation that was created, but we now put into the ingredients, or the pot of soup, sometimes I refer to, things that people can relate to. So we talk it begins advocacy, we talk about the environment, we talk about behavioral, financial, but that comes each week. One of the most fascinating things I want to touch on right now while it's in my mind, Reverend Robin Anderson stated that a participant gave back their stipends. In cohort 5, during COVID, we had to go virtual. It was a new experience for folks, and we do it in session, but because of COVID, we did it on virtual. And they started talking about being grateful, talking about what impacts them. And that class decided at the end of their 22 weeks that they would make donations to nonprofit organizations. And they picked organizations that were, meant something to them. The AIDS Foundation, they talked about Make-A-Wish Foundation, the Connecticut Food Bank, as well as a shelter. And that gave them so much joy because, when folks are in their substance use journey, they feel like they have nothing to give back. And they found that in the 22 weeks of class that, you know what, I might be struggling. I might think that I have nothing to offer, but collectively as a group, we can do this. And it's not about the amount of their gift. It was the amount of their sacrifice. And that was so heartwarming for the facilitators. We at New Haven have currently 5 facilitators, 2 alternates in the event that someone's not there. I have seen people who the age of 19 to 65 years old come into our groups. The great thing about doing this group is it's self-paced, but it's a family at the same time. Our subjects can get really intense, but again, it's a non-judgmental zone, and people are just really being truthful. They feel like the space is safe. We're not preaching Jesus to them, although that is our belief, but whatever they believe in their higher power, it is certainly welcome in that space. This program, I can tell you from a personal point, is that I thought we came to help them, but they actually came to save our lives. This is something that we constantly work on the subjects. We do things from, one of my favorite subjects is the vision statement. We ask them to draw their hand on a sheet of paper that is comes in combination with the self-love. We talk about self-love, and it's interesting to see how folks feel like they are last on the list. And when we engage in conversation, when we do self-love, realizing that, you know what, I'm not selfish if I love myself, because if I can't, how can I love others if I can't love myself? So it's prioritizing their emotion, their feelings in their journey in recovery, feeling self-worth and feel like they need it. And we tie that in. All of our subjects are tied to the 5 R's of citizenship. Just recently, last week, we had them do an assignment. They're in next step, goal setting. And we asked them to find out who your legislator or alderperson is in your neighborhood. Call them, introduce yourself, tell them that you're part of the Money Breakthrough Project, and what kind of resources do they have for people in recovery. Well, 3 people came back out of 12 people with the assignment. They came back. One gentleman says, I know who my alderperson is. I introduced myself to him, and he told me there are a lot of resources for someone like me, and he would like for me to call him back. That is the advocacy tool. That's putting themselves out there. That is considered their role. It is responsibility, and it's their right to be able to use the same resources as anyone else living in their community. The other person talked about, I know who my alderperson is. I introduced myself. I told her about my substance use, and she says she wants me to get better. She's seen me at events. And so it's their way of engaging back into the world where they felt like they did not belong. This has been some of the things that I've encountered. This is God sent, but it's definitely something that it works. It's not a fairy tale. We don't always have Cinderella stories, but for me, living in the community, we get to ride this journey with them, because sometimes people do slip back. Sometimes they do have a fall. And when I walk out of my house or when I'm going into my church, people are not ashamed to show you their brokenness. And this has been I can tell you 100 more stories, but I am respectful of time, and I'd like to be able to have Pastor Jose Rodriguez speak. Thank you so much.
Amen. Greetings to all. Well, I'm humbly honored, and it's a blessing to be here, in the midst of every single one of you guys. Reverend Robin, you couldn't have said it any better. I remember the first day you came to our church 3 years ago to present the Money Breakthrough Recovery Program. And fast forward 3 years, it's been a huge blessing, and it has also been a key component within our ministry. Real quickly, because I know in terms of the time, I'm also been in recovery. It's been 27 years. Before the 27 years, I was known by an inmate number. I'm also a father of 8, multicultural ministry, pastor, my wife of 24 years. So it's been a blessing. It's been a blessing. And I'm also a aerospace machinist. And sometimes I ask myself, and people say, well, how do you make time for the Imani Breakthrough Recovery Program? And it's only just by the grace of God. So once again, the Imani Breakthrough Latino here in New Britain has been a great blessing to our city. Also, our sponsor support system, I mean, has been phenomenal. And I would say within these 22 weeks, as Sylvia had mentioned, those 22 weeks, I mean, those group sessions has been a blessing also to our participants. And also followed by the next step, because we just finished a 12-week group session. And seeing their faces receive their first certificate, maybe they have never received a certificate before. And seeing them receive that certificate, I mean, the smile on their faces have been amazing. And now we're actually on our last 10 weeks, and we actually have a graduation now in March, and they're excited for this graduation. You know, the workshop has been phenomenal as well, the workaround support system. And one of the things that I believe that they understand is that the Imani Breakthrough is not a treatment, that we are a recovery support group. And when they understand that, I mean, it's just amazing that that they feel loved on, that they have that sense of belonging, that they still have another opportunity. Before those 27 years, I mean, I thought I didn't had a chance because of my background. But when you're able to provide that, that, hey, there is another chance. You do have another chance, you know, in life. And that's why I love one of the components, you know, with the 5 R's is that, you know, you give them that sense of responsibility, that they understand that there are resources out there for them. Some of them maybe feel stuck, but when you build and you become that bridge for them, you know, and they're able to excel, to build relationship back with their families, that they do have rights within our communities. That's powerful all by itself. Just 2 or 3 days ago, we took 2 people to go get their IDs, just their regular IDs, not even a driver's license. And one of our participants wanted to post it up online. Like, she was like, in 40 years, this is the first time I've ever received an ID. I mean, an ID, but for them, it's just beautiful. And then her next step would be to get her driver's license. We also have another participant where we were able to help, you know, with the help of, you know, the letters through Graciela. Thank you very much. Those letters were very, very, very helpful. She was able to obtain housing as well. And not only did she obtain housing, mind you, she was homeless, and she was able to receive 2 of her sons back. And those 2 kids of hers are 2 of our church members within our youth group. And that's just a beautiful, beautiful feeling. And just 2 weeks ago, the father just came out of jail, and we're actually in the process of that transition as well. We had another participant where, you know, he had mental problems. And I love the pastoral ministry because we deal with all types of groups, all type of ethnicity background. And as Sylvia said, you know, it's a judgment-free zone, you know, and this person had, you know, some serious mental problems, and we were able to get him into a program, and that first program did not work out for him. And we as pastors, we picked him up, we put him into another program, and that didn't work out for him. Then we took him to another program in Waterbury. And in this program, he has had already full recovery. And I believe he's about to graduate from the program. He was in a 6-month program, and he's about to come home soon. So what I mean by saying this is that, you know, we don't give up on people. And when they see that you don't give up on them, they have that sense like, wow, you know what, I can do it. And I want to end by saying this, that I took these 2 of our participants and I took them out to dinner. And one of the participants, it's kind of touching because I mean, I do have my live experience. And I only took them to Applebee's. And that to them was just life-changing. They said that the first and last time they ever went to an Applebee's was when their grandmother was alive. So, you know, building that bond with them. And even after the 22-week programs, obviously as pastors, I mean, our jobs is 24/7. So many times, sometimes we get a call, and I'm quite sure Reverend Robin can relate. You know, you get those 1 o'clock, you know, calls, 2 o'clock, and we answer. That's just our job within our community. So once again, I thank the Imani Breakthrough Recovery Program, Cheryl, Sylvia, I mean, every single one of you, Graciela, Mark, you know, for the opportunity that you have given Oasis of Blessing here in our great city of New Britain, to bring the Imani Breakthrough Recovery Program, which has been a huge, huge blessing in our community. And also, even when they can't make it to our meetings, the first thing that they do is they find a way to text me. Can we do a Zoom? Can we go through Zoom? Or if they're sick, I mean, they do stay home, and they make sure that they get that Zoom call in at least. So I thank you very, you know, once again, and I just turn it over to Cheryl. Thank you.
Thank you so much. I'm always moved by the stories of you all talking about the work on the ground, and we really appreciate you because you're the ones that are doing the work. I just want to quickly, we have about 5 minutes or so, and have Dr. Mark Costa talk about our data and findings. Mark, can you join us? And if we can get the slides to that section, that would be great.
Thank you. Hi, everybody. I'm Mark Costa. I'm a Latinx psychiatrist from Brazil. I feel very blessed to be part of this team, this amazing team. I personally have my story as my father struggled with alcohol use most of my life. And if you can pass to the next slide, we can see that I'd like to remind folks that most of our participants, the majority or all of our participants, struggle with tremendous health disparity issues. And they struggle with history of incarceration, homelessness, unemployment. So we use 2 instruments to do data analysis or to follow people. One is the 8 dimensions of wellness. And in this sense, I like to acknowledge Maria O'Connell and Charlotte Nish in their very important work in helping with the data analysis. And as we can see with the 8 dimensions of wellness, we see a significant increase in all of the 8 dimensions, physical, intellectual, environmental, spiritual, social, occupational, emotional, financial, and in working. So in 12 weeks, they have this very important and significant increase in their 8 dimensions of wellness. Next slide. Next slide, please. And another instrument that we use, sorry, Maria, thank you. The previous, please, is the 7 domains of citizenship. The 7 domains of citizenship after this one, Maria. Yeah, thank you. This is an instrument that measures the citizenship subscales. And again, personal responsibility, governmental infrastructure, caring for others, civil rights, choice, relationships, and legal rights and statewardship. There is also a significant increase in the 12 weeks during the program. Thank you again. Thank you so much. This team is amazing, and I feel so honored to be part of. Thank you.
Next slide, we have one more slide. So in terms of the quotes from the Imani participants, just wanted to point out a few of the comments from participants. And one is related to self-actualization. In the beginning, I was not able to recognize that things get better. I learned from everyone here that I could be better every single day. And another one, I improved myself. I'm better for myself. I came to believe that I don't need drugs. I really like to talk. I like the feeling. I'm not afraid to talk anymore. So those are just a few of the comments. And we have one final slide, and I'm going to have Graciela Reyes just take us out with that one. Thank you.
Thank you, Dr. Cheryl. We're learning new lessons every day at Imani. So I just want to say that the lessons that you learn, it's relate to the importance of have a church liaison, offer program that respect culture. It's the collaboration with all the facilitators, the support that we have from the community. And I think the most important thing is Imani is at the community. It's about engagement. It's about to listen to stories and connect with the people in day-by-day life. So thank you so much. And I'm looking forward to continue this conversation and any other opportunity that we have. Feel free to contact us. And the information about this presentation will be available tomorrow. Thank you all.
Thank you. If there are any questions, we're going to move on to a mindfulness moment, but feel free to put your questions in chat and we will respond to them. Thank you.
Thank you for the entire team for an amazing presentation. What an amazing project. So now what we do is, since we're here with 2 hours, we invite you to really just take a moment to listen to this mindful moment, just so you can relax and just be recharged for the next conversation we're gonna have. So let me make sure that I am sharing my sound for video clip and have a wonderful moment here.
When you are in the throes of an overwhelming emotion, it can hook you in completely. Mindfulness practice helps you notice when this happens. When you do notice that you are feeling overwhelmed, you can use this exercise to bring yourself back to the here and now. It takes just a few minutes and extends an invitation to be present. Leaving the eyes open, notice 5 things that you can see. You can say them out loud or silently in your head. With each of the 5 sights, pause to take them in completely. And remember to take in deep breaths through your nose into your belly and exhale completely. Next, notice 4 things you can feel in the body. Note them out loud or in your head and rest your attention with each sensation for a few deep breaths. Name 3 things you can hear. Try to choose 3 different sounds. Remember to keep breathing in through your nose and exhaling completely. Note 2 things you can smell. If you cannot seem to smell 2 things in this moment, think of 2 things you have smelled recently, or feel free to move somewhere else to smell something more closely. Finally, find 1 thing you can taste. It may be the leftover taste of a meal, your toothpaste, or just your breath. If you cannot connect with 1 taste in the moment, note a taste you enjoy in general.
Welcome back. I am going to have to just stop for 1 second the sharing so we can prepare for the next session. So just please wait a moment and just take it all in. I have to switch the slides here. So
I don't have a question, but I do want to say, this is Cheryl Bellamy again. We are so excited about the work of the Armani Breakthrough, and excited to announce that we were just recently funded by NIH in the form of what they call a U01 to further study the Armani Breakthrough project and its effectiveness, just really working with Black and Latinx folks and helping them to reduce substances. So we, over the next 5 years, myself and Ayana Jordan and the team will be continuing the work of Imani. We're going to study it as a randomized controlled trial, which means that we will be able to look at the results and have evidence about its effectiveness. One of the key things that we're building into this randomized controlled trial is choice. And choice is a very complicated thing to study. We have, our statistician, Cheryl Nietzsche on the call. I'm not going to get her to describe it, but I'm just so excited that we're able to really look at choice, because we know that that is a key issue that SAMHSA talks about, and we know it's a key and important thing that our folks in the community are talking about in terms of what will be more effective for them, and having that choice to make the decision about ways in which recovery is important to them, and choosing even when they're ready for it. So we're excited about it, and we'll be in touch as we begin this.
Thank you so much. And please, if you're here in New England, feel free to reach out. We'll love to make that connection happen for you as well. So we have another video to introduce our next session. So just again, let's do this again. For the next hour, we're going to be continuing the conversation not only about recovery, lived experience, and communities of color, but we are going to be, it is my pleasure to introduce the Assistant Regional Administrator of SAMHSA Region 1, Taylor Bryan Turney, who will be participating via special video offering. Taylor will introduce herself and her powerful testimony around the importance of collaborations between the schools, healthcare centers, CBOs, and as a part of her presentation. So I'm just going to play her powerful. Taylor is an amazing collaborator with the Heart Collective, and where we're going to be presenting, which is part of the New England Mental Health TTC School Mental Health Work. Just gonna please listen to her words.
Good afternoon. My name is Taylor Bryan Turner, Assistant Regional Administrator for SAMHSA, Region 1, New England. It is my pleasure to tell you about the healthcare workers and educators addressing and reducing trauma collective. I think the name says it all. But first, I'd love to tell you a little bit about why the Heart Collective is so near and dear to me. So here I am, 5 years old, living in Brooklyn, New York, living in the projects or affordable housing, only child at the time before my 2 younger sisters come along. So I'm living my best life. When I was 8, my parents headed to New England to escape the Bedford-Stuyvesant projects for a safer life, a more equitable life, and access to economic mobility. Things were going according to plan, and Mom and Dad had great jobs. But when I was 15, there was a mass shooting at a local bar in Providence, Rhode Island, and a person under the influence shot through windows of a bar, and several people were harmed. My father sat at the bar when a person got up, and a gunshot wound caused him to be wheelchair bound, a quadriplegic, paralyzed from the neck down for the rest of his life. His biggest fear was being incarcerated just for living as a Black man. And now here he is, a prisoner in his own body for the rest of his life. This caused me to be a young nurse, physical therapist, and extremely adaptable. I had to grow up fast, started working right away to help Mom, and went to 3 different high schools because we had to move around a lot. to provide that accessible housing to accommodate my father's needs. These are multiple traumas and had a major impact on my family. And I want there to be accessible mental health supports to all children. And the best place I can think of is in our schools. These are the resources that I did not have access to. So why did we convene the Heart Collective? Well, COVID-19 increased the need for school mental health, stress, anxiety, depression, suicide ideation, and substance use among youth are at an all-time high. Schools are underfunded. We wanted to work with HRSA because HRSA was funding the community health centers who are caring for youth in our communities. And we wanted to work with the schools because that's where our children spend most of their days. And while we all want the same things for our youth, we knew access and coming to consensus can be hard. So I approached the New England Mental Health Technology Transfer Center for their school mental health initiative because of their work promoting community-based collaborations to reduce trauma through school mental health systems using this compassionate school mental health model. With the Heart Collective, we helped revise and refine this plan. The statement of values you see here provides all members of the community, including the youth and their families, an opportunity to be heard and contribute to the mission and the model. So HEART was formed. HEART is an intentional collaboration between the MHTTC, HRSA, Health Resources and Services Administration, and SAMHSA to bring mental health supports to schools in an effort to train, support, and strengthen compassionate social and emotional learning. There are barriers to school perspective, as well as the healthcare center and lived experience perspective. To go over some of the barriers that get in the way of us collectively doing this work, we had to bring together regional leaders in education, healthcare, family advocacy, and lived experience to identify the barriers, to learn from the experts in community on what's working well and how HEART might address these challenges and turn them into solutions with HRSA's grantees, and then drawing in the other TTCs to help realize it. Now, let me be clear. FQHCs and schools looked forward to working together, and some were already doing the work, but HEART really thrives to perfect those relationships. So barriers included funding, mental health supports, lack of information, staff burnout, a unison glossary was needed early on, and pushback on roles and who should be responsible for what. Many of these barriers are unique, but many also overlap. Also, diversity and lived experience was a critical component on developing and executing a plan. The most critical component of this work remains our youth, the very audience we wish to reach, gain trust, and transform. So it was imperative that we keep that engagement open and sacred as we work to alleviate their stresses and anxieties and traumas. Many children's homes have been turned upside down during the pandemic, as well as teachers and providers, due to the many lives, about 900,000, we've lost during the pandemic. But the time for innovation and collaboration could not be more prevalent. And since HEART has formed, we have improved the compassionate school mental health model. We've convened a committee to build a community of educators and counselors who share best practices, and created a virtual community of practice for school-based mental health that is accessible to all. Please visit our new HEART website, where you will find information on our mental health awareness campaign and gain access to our webinars. In fact, later today at 4 o'clock, you can join the conversation about what funding and logistics considerations have worked for others. I feel very fortunate that I get to work on this team and help to provide some form of safety for children experiencing trauma during grade school, as I once did. And I'm truly grateful for each member of HEART for providing a space for compassionate and social emotional learning. On behalf of the MHTTC, SAMHSA, HRSA, and the entire HEART Collective, thank you for helping to amplify this work and the opportunity to share with you today. Please enjoy the rest of the conference and have a good afternoon.
Wow, what a powerful story from Taylor's life. And she has been an amazing collaborator for the New England Mental Seal and supported of this. So now I'm going to turn it over to our collaborator from Boston Public Schools, and Andrea Amador. She's the Assistant Director of the Boston Public School Behavioral Health Service, and she's here to share with us a very innovative program as well. So Andrea, I think I will be advancing to your slides. Bear with me, I just got the slides here, so I want to make sure these are the right ones. Okay, here we go, Andrea.
Thank you so much. I'm honored to be here today to represent the work of our team in behavioral health services and our partners. But before I begin, I just want to thank the first presenters. You've really inspired me. We do work with faith-based leaders, and I can talk a little bit about that, but you've really given me some wonderful ideas of how we could expand what we're doing. So I'm here today to talk with you about how the Boston Public Schools, in collaboration with UMass Boston and Boston Children's Hospital, have developed what we call the comprehensive behavioral health model, and have really tried to integrate children's mental health both within the schools, but across community partners, both within the community and within the schools. And one of the many reasons we started this was to ensure equitable access to mental health services for all of our students. And we also wanted to address the barriers that families face in trying to get community mental health services. And we wanted to ensure that any student in BPS, regardless of the school, was receiving mental health support and a safe and supportive environment. I developed this presentation with Dr. Cheryl Dannery from Children's Hospital. Unfortunately, she has another commitment today, but we wanted to make sure to maintain her slides so that you and we could share with all the participants the incredible free resources Children's Hospital has for anyone. So thank you, Maria. So as we move on, I'm going to talk, I could go way over time, but I'm going to try really hard, and Maria's going to remind me if I'm getting over time. But in general, we really wanted to share with you some highlights of how we've developed comprehensive behavioral health in schools. So these are some of our agendas, and I'll move on and share with you just a tiny bit about our district so you know about our wonderful students. We do have many schools and many students, and like all urban districts during COVID, these numbers have since dropped some, and we anticipate an official lower enrollment for next school year as many families left cities during COVID. But we are an urban district with a minority. Our minority students are the majority of our district, with our Hispanic students being the highest percentage. We're super proud that our students and their families speak over 100 languages. And as other people have said, we really have to be very intentional about how we're providing culturally and linguistically sustaining mental health services. So if we are not working with our families, working with our partners in the communities, in our students' neighborhoods, in our schools, then we're not serving our students properly. So as I move on, I'll tell you about our staffing very briefly. My department that I have the pleasure of leading is made up of school psychologists who are committed to what we call the National Association of School Psychologists practice model. That means they're providing a continuum of behavioral health support, from prevention and creating safe schools to finding students at risk using a universal screener and getting them help before they need higher levels of care. And then providing traditional intensive mental health services that folks are familiar with, such as counseling, assessment, suicide risk assessment, threat risk assessment. It's important to note that this change in service delivery was done because we knew that as mental health providers, we were not meeting the needs of kids. So BPS school psychologists shifted their practice to meet the needs of kids. And I think it's a common theme you're going to hear through the presenters today, that as a history across several types of mental health services. We've not always met our students or families or children or clients, whichever lens you use, in ways that were meaningful to honor their culture, their heritage, their lived experience. And we in schools are doing that journey as well, and saying, how do we pivot as professional mental health providers to meet the needs of our families? Thank you, Maria. And so this slide has a little bit of old data. We have new data. We do this every month, but I just wanted to give you a visual to show that historically school psychologists just did evaluations for special education, but we really pivoted and said, in order to provide that comprehensive behavioral health, we have to have strong skills to prevent behavioral health need, to get in there when a trauma has occurred and provide quality, culturally and linguistically sustaining crisis responses. And then we need to work with school teams so kids are getting what they need. And that's, this graph intends to show you that. So as I move forward, thank you, Maria. I want to acknowledge our deep, meaningful and long-term partnership with Children's Hospital. Boston Children's Hospital has a world-class reputation for providing the highest quality healthcare for kids, but they're also a research institute, and they have a community mission. And without them, I couldn't have accomplished some of the things we're here to talk to you about. Their hospital has really recentered itself to say, as we are treating patients from around the world, how are we also giving care to the kids in our own community that we serve? And to date, they've given almost $2 million to help support the behavioral health of the Boston's public school kids. So I really want to say, they don't just say they have a community mission, they live it every day. Thank you, Maria. And so a couple of things that Dr. Charlotte Dennery's team does, we overlap so incredibly that she could be here talking to you about my work, and I can be talking to you about her work, because we've developed this in conjunction. And that's a really critical piece that I also heard our first presenter say, that it's not one group saying, I know what's best for you and I'm going to come do it. It's let's together look at the needs of our particular stakeholders and develop it together. So Children's has been a wonderful partner in that way. And they have a program that comes into these schools and has clinicians in the schools to provide a range of behavioral health services. So again, it's one of those ways that we are addressing the barriers to access to mental health. We're not saying to our families, you need to go to a hospital or clinic to get the mental health needs. We're going to come to you. They've also been an incredible advocate for the field at the state level, but also in the community level. They've helped us greatly advocate for increased needs for behavioral health students. So moving on, it gives you just an example, again, like my team, what they're doing from that prevention and promotion all the way up to those traditional mental health services. So both their program and ours is built on a public health model. But we're saying, yes, it's public health and everyone has a right to it, and let's bring it to them. Yeah, thank you, Maria. So moving on, we have some just connecting slides. Thank you, Maria. You can move on. Thank you. So why do we collaborate? Nope, you're good. We collaborate because we knew, as I've mentioned, that it's best for kids. We knew that we needed to have joint missions so that what Children's was doing was help building what we're doing. We knew together we could provide a higher quality service. We could do joint training for our staff, so that Shala's staff, who are traditionally trained in clinics, knew how to operate in schools, and that our school team knew how to partner with community partners and hospitals. But we've done this collaboration for 12 years now, in 80 schools supporting 33,000 students, but that takes a lot of effort. So we do like to acknowledge that. And you heard from the other group how much time and partnership it takes to talk to each other, make sure we're on the same page, and really understand each other's work. So we found to make sure that that's sustainable, we really have to think about the program together. Again, it's not us developing something and them just developing something different. We're working together. Much like this first group, we're also doing program evaluation. We need to say, is this working? Are we meeting the goals? Are kids getting better? One of our main issues has been in schools, how do we bridge the gap between evidence-based practices that have been developed in research and actually implementing them in schools? And so part of our mission is to be very intentional about developing shared goals with stakeholder feedback, and then implementing our interventions that we'll talk to you about, and then making sure that we're getting good outcomes and saying, does this practice improve behavioral health outcomes for students? And so, I think we went far. If we could
Andrea,
pick up a few
yes,
minutes.
coming towards the end. So I don't know which one you want to summarize. And I mean, people have access to the presentation for the entire presentation. We'll put it up with the products.
So, okay, if you can, I'm sorry. The joys of technology. Keep going, Maria, and I'll ask you to stop. Yeah.
Oh.
So some of the things we've learned is what I had started to say, that we need to have leadership. We need to work together on funding. We need to make sure we're having authentic stakeholder engagement, not pretending to get people's feedback, but actually getting them feedback. And I want to just take a minute to tell you what we're actually doing, because I think we skipped that slide. So what we're doing is together, we go into these 81 schools. We help make sure that we're starting at tier 1 and having strong prevention. So we're looking at how do we build positive behavioral health, not just address behavioral health issues. We want to build strong skills that will help our students through life, career, and relationships in the future. Then we use a universal screening to say which students have needs, and let's get them needs where when they're just showing risk factors, instead of waiting until a student has a mental health crisis to get them support. We've been advocating for more positions. So the exciting news that I did want to end by sharing is we now have a social worker in every BPS school. When we started, we had 6 district social workers. We now have 157. When we first started this collaboration, we had about 25 schools with a mental health partner. We now have 100 schools with a mental health partner. We started with 48 school psychologists, and next year we're going to have 107. So part of it is developing good practice that's culturally and linguistically sustaining, but then it's also making sure we're advocating for what our families need. And now every student in BPS has pretty much doubled their access to mental health services in schools. So I'll leave it at that, Maria, in the interest of time, but encourage anyone to ask me questions in the chat. And our website is cbhmboston.com. And it has a link also to Sheila's materials. And she has an entire website of free materials. So thank you all.
So much. And yes, I know we could use a lot of longer time. Unfortunately, this is the only time we do. But as we said, what's very interesting, and I think if you attended day 1 of the conference, we talk about collaboration. I think throughout the whole week it's been about collaboration. This week in itself is about collaboration with each other. When we are together, we work much better. This is definitely something we are doing regionally with the TTC. So I appreciate that. And the preventions focus that you brought, which was discussed on day 2 of the conference. So now we move to the last panelist. Okay, so where did my presentation went? I'm sorry, this navigating this many screens here is a little bit here we go. Okay. So now, oops, from current slide. Okay, Now it is my honor to introduce a very dear project to me, the understanding the expertise of lived experience. We are joined by an amazing peer leaders within New England, Dan Johnston, Christina Rosari, and Annette Diaz. Unfortunately, Moon Machar wasn't able to join us today. These fellows graduated from what's called the New England's Lived Experience Transformational Leadership. I have the honor to, in partnership with Dr. Cheryl Bellamy, to be part of the Let's Lead Academy from the beginning, not the beginning of the history, but definitely writing the curriculum and being part of the amazing cohorts that we've been leading for a few years now. So is just to give you a little bit of a context, just because the fellows we're going about to hear graduated from this Leslie Transformational Leadership Academy began at the Yale Program on Recovery and Community Health that you have heard today. And these were leaders around the world that got together, including Dr. Bellamy and Dr. Davidson present here today, people with Canada, and really did a study and a survey and understood that there is a very, the need to really provide opportunities for people who live experience to take leadership. And so there was an overwhelming yes, and we got funding from SAMHSA as well to pilot a curriculum, which is when I actually joined the experience. So why now? When we're talking about all the communities we're talking about, I can only tell you for me, this experience as a person with Latina immigrant who experienced a lot of trauma around cancer, and also as a family member, this transformation, this leadership for me, and as a leader in this field, I use my lived experience every time. This experience, this leadership is something that really informs who we are, what we bring, and our values. So it's definitely something that I use on an everyday of the lives. And when I talk about transformational leadership, what we're talking about is we understand, and it is so important if we are really going to be thinking about equity, that we understand intersectionality of critical and emergent issues in behavioral health and many other systems of care, including schools, as we just heard. We need to understand that when we lead, we need to practice appreciative inquiry and transform communities, especially communities that are disenfranchised. And also we know with this academy, and what you're going to hear from these fellows is they learned, they were accepted into this academy, which is our own New England region in partnership with the New England Mental Health TTC. And they all developed an amazing project that where they were able to combine the knowledge and the skill they gain so they can improve lives of all of us in the community. Leaders that have this transformation are committed to applying diversity, equity, and inclusion lens to leadership. We heard Janet Hernandez on yesterday, how powerful the stories and all the videos we had heard, even today's Taylor's video. It is so important to be actively committed, actively engaging, and really having an equity lens in all the things that we do. So as with further ado that I am going, this is our amazing team, Dr. Cheryl Bellamy, Dana Asby, who's also part of the HEART team and the New England Mental Health TTC, and Heather McDonald. We are all now doing, this is also an international program. So for further information, please visit our websites. So with further ado, I'm going to turn it over to Dan. Then we'll hear from Christine, and then we'll hear from Annette Diaz. Dan?
Thank you very much, Maria. And really so honored to be here with everybody here today and to share my story and a bit more with all y'all. So yeah, hi, my name's Dan Johnston. I'm a writer, a peer specialist, and a Let's Lead New England fellow. My presentation's about the opportunities of recovery-oriented approaches to mental health care, such as early intervention in treating psychosis, and how it can be improved to better serve diverse communities. So to begin with my fellowship in Let's Lead, I focused on storytelling, on how recovery can be fomented by sharing lived experience to both reflect on our own journey and to support others in theirs. Doing so included teaching writing workshops, developing my own writing, and exploring some of the literature on how creating personal narratives impacts our own identities. A lot of this emerges from sharing my lived experience of early intervention for years, as well as now supporting others to create their own narratives as agents of their recovery. So I begin here to show how sharing the expertise of lived experience continues to lead to new discoveries, both personal and otherwise, and how strengths-based and recovery-oriented treatments like early intervention can supplement lifelong pursuits. I grew up in the suburbs of Boston, where I was surrounded by loving family and friends engaged in activities such as sports, music, and church. I was a good student in school, and I excelled particularly in writing. College was always an expectation in my privileged upbringing, and when I was accepted, I felt my mission was complete. I thought the stress of thinking about my academic future would dissipate, and as would the change that I was beginning to notice in my thinking. The intrigue with a blurry area between nonsense and creativity, sort of a fascination with random things. The fascination remained when I got to college, and for a while, it didn't cause a disruption in my studies, writing, or social life. However, after a few semesters, thank you, Maria, for changing the slides. This is a quote that I'll just leave in the background, and we can ruminate on it all together. So when I got to college, I found that I wasn't speaking or writing the way that I knew I could. I was incorrectly diagnosed with ADHD at the age of 19 when I was prescribed Adderall. I also sought out marijuana as a means of understanding what was happening in my thinking. Rather than devoting my time to class, I tried to grasp the past strength of mine through writing creatively. Things like, I'm styling like a lion, I'm resolved, self-reliant, like a hominid, yeah, I did, the evolved client. Now among them, I'm a giant. Which aren't bad rhymes, but they failed to boost my spirits given that the numerous essays I had to write for class still remained in their primordial forms. I was confused why my thinking was changing. And when speaking with friends, sleeping, and generally enjoying things became difficult too, I withdrew from school. In the time that followed, I tried other approaches. I got a job on a whim, cooking in New Mexico in the desert, thinking I just needed to get away. I returned home more lost and confused than ever, and received diagnoses of depression and anxiety, and none of which seemed right. I eventually heard the word psychosis a year after I left school. I feared that if it was the case, the way of thinking that I'd known all my life would change. Months following that, I finally discovered an early intervention clinic that specialized in clinical high risk for developing psychosis. That was the first time I'd heard that phrase. And it oddly validated my experiences in that it gave me a visceral sense of relief that there was a modality of treatment that seemed like it could support me to get back to my former way of life. So I sought support when my experiences were disrupting the life I wanted. And I found that the focus of early intervention was on helping me as the individual navigate through those disruptions. I always felt that my self-determination was maintained through the programs in which I chose to participate, such as family support, group sessions, coaching, psychopharmacology, because they all catered to the values I wanted to return to. I found that early intervention set me on the way to continue the life that I wanted and gave me the perspective from my lived experience to work so that everyone had the same opportunities. So as this quote says, the wounded storyteller ending silences, creating truths, speaking truths, creating communities becomes the wounded healer. As of now, there is a lot of work to do to improve awareness and access to early intervention, especially in communities of color. The diagnoses along the psychosis spectrum carry a lot of stigma and discrimination, which essentially are the same thing on their own. But specifically and historically, diagnoses of psychosis have been used as tools of systemic racism to institutionalize Black men, such as during the civil rights movement after the wording of the definition of schizophrenia was twisted to create more lasting disruptions. So not only is the issue of discrimination based on diagnoses, but the intersectionality of racial discrimination and pertinence to Black, Indigenous, and people of color, and just in general communities of color. So the promise of early intervention, I do think exists, but not only because of the intersectionality of that creates a barrier for people of color participating in early intervention, but also given the fact that the primary body of research that's done into the effectiveness of early intervention is done in white populations, there are many ways for us to improve this modality. First of all, partnerships with community health centers, geographically based and underserved communities, brings these interventions much to the forefront. And as we saw in the Armani perspective, the Heart Collective, and in Boston Public Schools, there is a lot of work being done to encourage recovery-oriented models in schools, churches, and otherwise. A lot of funding is only based on billable services such as treatment. Redirecting funding to specific outreach into communities of color would, at least begin the conversation in a way that would bring these services to a more equity-based area. Also, there have been recent developments in research, such as John Delman's recently published Barriers and Facilitators to Vocational Development of Black Young Adults, which analyzes the correlation between diagnosis of psychosis and education and jobs, as well as Nev Jones' qualitative work in terms of illustrating the stories of people of color receiving treatment within first episode clinics. Along with that, changing the language used to refer to psychosis and schizophrenia, which has also been recently published by a group from the Massachusetts Mental Health Center, which I am a part, and is ongoing in its discussion. And basically just to carry on the hope of this opportunity for us all to, understand that recovery is real, and detecting and providing these resources earlier will create hope for all our communities. And with that, I will send it off to my fellow Let's Lead New England fellow, Christine.
Yes, Dan, how amazing. I'm so happy to see you, and I'm so glad and honored to be here. When I was, hearing all the presentations before us, I was so impressed with all the work that people are doing throughout. So thank you for inviting me. Maria, can you go on to the next slide? So my name is Christina Rosari. I am a program director for the Gundara Center. We're located in Holyoke, Massachusetts, but we have offices statewide. I've worked with youth and young adults for over 12 years, and I am a New England Fellow. And today I'm going to talk about my presentation. Is going to be a little bit about how my project, my New England Fellow project, go back, Maria, real quick. I'm not there yet. And how you know, a lot of my lived experience, and how am I going to train people to kind of work with youth and young adults to share their lived experience and so on. So next slide. So the first thing is to understand when I'm talking to young adults and those who provide services to young adults is, what does mental health recovery mean to you? Have you heard the expression that recovery doesn't happen overnight? This is especially true in cases of mental health well-being. Mental health recovery is a critical milestone towards lasting healing, and it doesn't happen overnight. Recovery can be really hard, especially if culturally mental health is not a thing. This is particularly important to recognize for youth and young adults. Youth and young adults, specifically in the Latinx and in the BIPOC population, a lot of them, their mental health is not being recognized. People think that it's just, their age, or they just want to act up for certain reasons. So we need to understand what recovery means to them. I did some research and I asked a group of people what mental health recovery meant to them. And the results were pretty incredible. Some of them said, and I wrote it down, it's long, it hurts, leads to happiness, leads to a new you, and it leads to taking control. So keep these things in mind. Next slide, please. Resiliency. Positivity is the best encouragement. When youth and young adults understand what mental health means to them, they become more aware on how resilient they are. When I enrolled in the Yale Leads Academy, I was concerned that I would have to go back into moments that I had hidden. But then I was encountered with encouragement and a place to be me, a place to share my lived experience, and a place where other people had overcome similar situations, which made me reflect on the work that I do daily. How do I promote that same environment in my workplace? So I asked myself this question: what do I most want for myself? What do I most want for my children or the people I love? And that made me think about happiness and resiliency. So how do we do this? I looked into those very traumatic moments to see the meaning that gave me in life, and how I have a dad who struggles with substance use and a mom who's dealing with mental health as long as I can remember. I had a very traumatic childhood, but now I use those experiences to promote hope and encouragement in others. Next slide, please. Purpose. So peer mentor and peer support has exploded in the last decade, and we're fortunate that New England has adopted to that model. But how can we support someone's purpose? It's easy. Suspend your own judgment, ideas, and beliefs. Sometimes we are so concerned about sharing a piece of ourselves, but that piece can encourage someone's purpose. Just remember, everything we share should be with intent and to give hope. Next slide, Maria. Opportunity. As a person with lived experience in the Hispanic and Latinx population, I had to work extra hard to find opportunities that meant not giving up. I tell everyone the same thing: don't give up, even if it seems really hard. And that makes me think about those bullet points that I posted. Please, when you're dealing with someone with lived experience, help them promote growth, be equal, come down to their level, encourage them, build trust, and be vulnerable. That is important when engaging and working with people with lived experience. And then I have my information in the last slide. Maria, I don't know if you want to share that. Here's my information. And there's a way to contact me. I know that all this information will be posted tomorrow. And thank you so much for having me. I will pass it along to my fellow leads, Annette.
Hi everybody, I'm Annette Diaz, like thinking over here, where am I gonna start? I'm a person, I'm a Spanish woman with lived experience in recovery and mental health. And how do I say? So after I obtained recovery, right? After I got a hold of, or got engaged into my own recovery, let me say that, I started to find out about peer support. And once I connected to peer support, it was like my oxygen that I was breathing. And then I really took a passion into advocating because, you know, growing up in a household where, like, you know, mental health, again, wasn't discussed. I had to go to church, I had to pray, just all these things that were just did not help me, I guess, be okay with myself and my diagnosis. So once I learned I had rights and responsibilities, and like, oh my goodness, I was so amazed. So I took it and I went gung-ho with it. And I know one of the biggest things that I did was I worked as a regular recovery support specialist at a very large behavioral health agency over here in North Central Connecticut. And I worked there for a few years and I started seeing things, you know what I mean? Where's the change? Where's the change? I'm only one person, one human being. And we had their mission statement used to be like, we provide real life to real hope and real hope for real communities. And I used to be like, all right, well, let's put some, you know, put your money where your mouth is, because there was very little bit of people with lived experience working there. There was like 2 or 3 when I got there. I want to say this was like in 2010, and I was, you know, where's the ratio? Where's the diversity, right? So I challenged, you know, executive management. Actually, let me back up a little bit. A girlfriend of mine used to work there with me. We had worked for a smaller nonprofit, and our grant finished, so we went over there, and she was there part-time, and she struggled with some stuff, and she quit because she started to see, like, when people would come in to see their workers or whatever, the workers would be like, tell them I'm not here. And, you know, that's not what peer special, we're like, why would we do that? So she got mad one day and she left. She had her own struggles, you know, she ended up taking her own life, and it really pissed me off. And I went back to my agency, and I was like, I quit. You know, you have to change these things. Like, you're here helping people get better, but, you know, you can improve here, here, here. So I challenged them, and I made myself a position over there as the coordinator of recovery support services. So I was doing that for a few years. And then what Let's Lead did for me was enhance that role into bringing the recovery support services in that agency. It taught me like the business side of things, because for a long time I run on emotions, you know, and sometimes my passion can get misunderstood, you know. So Let's Lead, the mentors, the education pieces, the modules, it taught me a whole different perspective of, like, agencies, liability, just like, you know, if I was to say something and want to try to promote something, I can talk to another person, like the mentor would totally understand me, right? But then it's like, well, how about we say it like this? And then when I brought it back to the agency, they were like, oh, okay, it made sense. So that really, really helped me out a lot. One of the things that, you know, it was 965 staff in that agency. So one of the things was to try to promote recovery everywhere, right? In all these different sites that we had. And so one of the things that we started was like a real life, real hope series. And it was, you know, stories of people with lived experience in many different areas, right? Like, maybe someone, you know, was in recovery from substance abuse. Maybe someone was in recovery from hearing voices. Maybe someone was in recovery from being homeless, whatever that may have been, you know, so that people could see the variety of recovery that's possible. And, you know, and it played a part too, where, like, I remember my old supervisor used to say that some of the staff are overworked, right? And they got that vicarious trauma and all this stuff. So I can understand now, right? Maybe not years ago, that, you know, someone's working with somebody, their caseload is off the hook and they don't even have time to breathe, how they can get frustrated with an individual, right? Not condoling it, but again, I felt like bringing in this type of happy culture would have helped with some more of the changes that, you know, I had planned in this, in when I was in that position. At first, they weren't well attended. I mean, it was not supported at all. There was like 2 or 3 people that showed up, you know. But again, I didn't quit. You know, I was able to build a relationship with certain service directors over there, and I tried to target those, you know, and then I would regroup to, like, the management, the executive leadership team. I was like, how can you help me promote this? You know, we can't really make it mandatory, but can we do it at a different hour? Can we do like a lunch thing where like, you know, the agency bought lunch and people came. So we tried, they did work with me into strategizing differently, because at the end of the day, you know, they really did want to help people recover, right? So that was my project with Let's Lead. And, you know, to this day, it has helped me, I want to say, calm down professionally, because I used to really go at people with change and wanting for people to get understood and wanting for people to get a job and things of that nature. You know, and then the Spanish piece for me, I had to go in differently as well. So like there was multiple positions for like recovery support specialists, but never like a Spanish one, right? For almost 10 years there, I was like the only Spanish woman there. And so like, and then to have these courageous conversations with them, well, why don't we put like bilingual preferred? And I always heard, well, that's not a requirement for the contract. And I'm like, well, why don't we just be creative? You know? So, you know, some battles I won, some battles I lost, you know, but I never gave up. And Let's Lead helped me create like a professional mentorship, you know, friendship. It was just comforting. It helped me internally, like my own self-esteem. It made me not feel inadequate. It made me feel that some of the ideas or the purpose of the reasoning of why I wanted to maybe, you know, create a policy or, you know, be involved in an interview or just, you know, provide some support or co-supervision to a staff was not like radical. It was the right thing to do. You know, it was just, you know, trying to change a whole culture shift. You know, it was going to take some time. So Let's Lead provided me with a lot of tools for that and support. And that's all I have.
Thank you. Thank you to all. Thank you, Annette, so much. So amazingly, congratulations. We did it on time. So this is the time for questions for the presenters. So please, probably the best thing is for you to raise your hand and I can, you know, we can unmute, you know, you can unmute yourself. I think Vanessa will be, now you will be able to unmute yourself. Okay, Dan.
Hello. I didn't.
Oh, I saw your hand. Sorry.
Oh, I was just thinking. Thank you all.
I have a quick question.
Go ahead.
I work in a more rural community and we're struggling to get the schools to be actively engaged in participating in like our Clyde survey data. Do you have any suggestions for how we can work with the school districts when that is the first step to forming our partnership?
Are you talking about like mental health screenings or?
Mental health screenings, prevention. One of our trends in the area is that children are getting alcohol from their parents with their permission versus without. And our three big risk factors are parents' favorable attitudes towards substance use, low commitment to school, and family conflict. So we're trying to figure out how to work with the schools as a partner and also recognize that the parents might not be our best resource.
It sounds like a complex issue that y'all are dealing with in your community. And, I would just in terms of, you know, supporting the individuals, just, and it does sound like the parents might be contributing to the problem, but just focusing on the kids as, you know, their own selves, which I mean is the focus of, you know, a lot of peer support, but especially in the situation that you described, it might be, you know, easier to work with someone, you know, in a more confidential kind of way, as opposed to immediately bring the family to consult on sort of effects or the the responses to screenings, which can be problematic in their own way, but it can create further conflict if that's shared explicitly.
I think that's one of the obstacles. The schools are very resistant to take the catalyst surveys, you know, in order for us to help gauge these trends as far as substance use and mental health. And the more that we try to talk to them, they shut it down, you know, that they have so much on their plate. But we don't want to do it as a way to beat the schools down. We just simply want to give them insight, you know, on a county level where they stand with things. But even opening the door to a conversation just seems like a struggle right now. I was wondering if you have any ideas how to get over that, like how to present this data in a way that is engaging and not critical.
I think it's just going to take time. I think, you know, take time, maybe try to find a way to build some relationships first. Because, you know, evolution takes time, and I know building relationships and trying to find, you know, creative ways. But I think this is a longer answer, you know what I mean?
Any additional question? As I said, we do have a lot of resources, and the Mental Health TTC Network has a school-based initiative. I think the HEART Collaborative, unfortunately, the speaker for the school couldn't stay with us today, but we'll definitely contact you and visit our website for additional information, and we will be happy to connect with you. Any other questions for any of the panelists? Remember to visit all the resources from the different programs are going to be on our website.
Maria, there's a question in the chat from Matt. He works as a peer counselor at a living room in Chicago, and he's wondering if there are any plans to move this model forward in New England, or is there something being operated in similar communities?
Thank you, Ingrid. Matt, are you referring to the Leslie Academy? He said yes. If it's about the Leslie Academy, we have not worked with New England. We have done projects internationally and locally as well in the US. We'll be very happy to connect with you. At the moment, we have no plans, but we'll be very happy to tell you a little bit more. I'm going to type my email on the chat, and you are very happy. You can definitely contact me, and we can understand.
I was just curious if you can hear me. I'm from Massachusetts. I grew up in Massachusetts, in Western Massachusetts, and I was a consumer of services in Western Mass in Northampton, and you know, I just recently got into this about a couple of years back, and the living rooms, there's a big push in Illinois for having living rooms in various communities in Chicago. And I was just curious, it's been such a driving force in diverse neighborhoods on the west and south side of Chicago. Is there plans for something like this to come to, you know, Boston and Worcester and Springfield? You know, I know there's some peer-run respites, but I was just curious if there was anything like a living room program out in New England.
Does anybody on the room knows? I'm not aware of that, but Dan?
I believe there's one in Framingham. I forget the name exactly of that one. I think the Hope Center is also in Boston through North Suffolk Community Health Center. So totally, Matt, the living room, you know, environment, just the welcoming place that it is, you know, it's around here, and it sounds like it's working great for y'all out in Chicago.
It's amazing, but it would be very cool. My goal is to do this maybe back in the community that I got my services, and to return, kind of to pass it on. And I was just curious, because it's been such a great model here in Illinois, and I know in other places. So I was just curious. Peer support.
Haner wants to talk. No, it's great. Go ahead, Haner.
Yes, thank you, Maria. There is a living room in Springfield, as well as a Hope Center run by the Behavioral Health Network.
Oh, very cool.
And they provide mental health as well as substance use disorder services. And in the living room, people can come in and stay up for like up to 72 hours.
That's awesome.
And there are groups and services there. Yeah.
Very cool. Very cool.
Excellent. Well, that was an amazing question. And this is exactly why we love to collaborate with everybody present, and these conversations will continue. At this time, this is all the time we do have. I'm just gonna do a final logistic, now current slide. So again, first and foremost, to our partners, thank you, William James College, the New England ATTC, the New England PTTC, and our own amazing staff. This has been an amazing experience. I hope you had learned so much as I had during the last 4 weeks. Remember, this is the first of many events as a region that we're collaborating together. Please visit our exhibit hall just to see all the resources that TTC exists in the region to help you to do training and technical assistance. And we are delighted to do this work in collaboration with the William James College faculty. Then, as you know, it's so important that you complete our GPRA requirement. We had an amazing attendance throughout the 4 days, and we really hope that when you get the follow-up email, you take the time to give us the feedback. We're here to continue to connect with you. Any questions, any of the presenters, please feel free to do. So thank you very much for spending the last 4 days with us. And today's presenters, thank you. Okay. So thank you and goodbye, everybody, for joining us.